All right, so we're going to talk about theater preparation. It's something that you are obviously doing since you're practicing anesthesia, but we just want to highlight some things. Remember, with the DA program, the most important thing is for you to be safe. So there are things that you might be doing in your practice which are not considered as being safe. So we want you to be safe. And for the exams, we want you to say the right things so that you are not perceived as being unsafe. So my focus in this tutorial is safety. And it's nothing new. The things that we're going to cover is everything that you probably do almost every day. So when I think of theater preparation, I like to have an approach. So I divide it into the patient. So in order to ensure safety in the theater environment, the focus should be patient focused. The other aspect is the equipment. And then the last aspect is to do with your drugs. So whenever you're taking a patient to theater, we have a patient for surgery who's been booked by the surgeons or for whatever reason coming in for theater, your approach should be one of a triad, focusing on the patient, the equipment, and the drugs. If you have this approach, you will never miss anything when you're preparing for theater. So starting with the patient, so it's very important to assess your patient very well, because if you don't assess the patient well, you are going to have problems intra-op. And not all patients are the same. As you can see in the picture, this is a young patient who probably has got good physiological reserve. This is a patient on oxygen. And when you're seeing a patient on oxygen, you should be asking yourself, why is she on oxygen? Why is she oxygen dependent? And if you can see that this patient is on a rebreather mask, which tells you she's receiving a high percentage of oxygen, a rebreather, it gives you about 97% of oxygen. And then you must also be thinking to yourself, what pathology does she have? Does she have a lung pathology? Does she have a cardiac pathology? So all those questions should be going on in your head. And if you've got an elderly patient, you should also be thinking all the considerations to do with an elderly patient. So you must understand your patient very well. And in order to understand your patient very well, you have to do a pre-op assessment. If it's an emergency, most of the time our pre-op assessments tend to be quite abbreviated. But for elective cases, you've got time to adequately see your patient. So according to evidence, doing a pre-op assessment reduces perioperative mortality by about 50%. So when I came across that in literature, I realized that pre-op assessments are extremely important. And if you are not doing pre-op assessments, you're doing an anesthetic which is compromised, and you are putting the lives of patients at risk. So 50% reduction in morbidity and mortality is huge. It means not doing a pre-op assessment, you are putting that patient at a huge risk. It's like flipping a coin. You're going into that operating room, putting the patient at risk by 50%. So it's very important to do a pre-op assessment. The pre-op assessment begins with history taking. I'm not going to go much into depth with that, but you know, everything that you did at medical school does apply, but it's kind of focused to the surgery, focused to the anesthetic. And we know with history taking, we're going to be asking about anesthetic history, history of allergies, family conditions that predispose patients to complications. Think about last month at Bedford, we had a patient who had an MH-like episode, and we had to call the patient with Dr. Folokwe, we called the father, to explain that if the child should come back again for an anesthetic, they must avoid a volatile anesthetic because that might be a life-threatening episode for that child. The child might actually die from being given a volatile. So history taking is very important. And the history taking also that will direct you as to what you should focus on the physical examination. So our physical examination in anesthesia is kind of three-pronged. So you look at the general health status of the patient. Yes, last night we had a patient with generalized body wasting with low albumin electrolyte imbalances. That patient is already very sick coming in for surgery. And you focus also on the airway examination. So as an anesthetist, your airway examination should focus on the difficulty or things that signify difficulty in masked ventilation, difficulty in laryngoscopy, difficulty in front of neck access. Those are the things that you should look at. And when you find those things, you should think of how can you make managing this airway easier. And you must think ahead, because planning will help you to mitigate failure in the perioperative setting. And then the last part of your physical examination is mainly focused. And in anesthesia, we focus on the cardiovascular system, the respiratory system. We may look at other systems as well, guided by the physical examination and the type of surgery that the patient is undergoing. But for most operations, we do a focused cardiovascular and respiratory examination. Investigations are important, and you can do bedside investigations like an ECG, urine dipstick, bedside echo, labs, your routine bloods, your urea, creatinine, HB, lung function tests, liver function tests if they're indicated. Your investigation should be directed by your physical exam and what the patient is going for. So for example, if a patient is going in for thyroid surgery, obviously in your laboratory investigations, you must check whether the patient is biochemically euthyroid. You wouldn't want to look for a thyroid, you wouldn't request for a thyroid function test for a patient who's coming in for a lumpectomy, for example, and the patient has no history of thyroid disease. So that would not be indicated. And then other investigations that you might require is maybe lung function tests, cardiopulmonary exercise testing. This is not on all patients, but it's directed by a physical examination and your history. Then after you've done all those things, history taking, physical examination, investigation, you risk stratify your patient. So after all of that, you should be able to come up with a plan. You should be able to say, this is a high risk patient, this is a low risk patient, this is an intermediate risk patient. And if you should then establish, is it safe to continue with this surgery or not? So for a DA anesthetist, you should be able to do ASA 1 patients, ASA 2. You may also do ASA 3 patients, depending on how the patient's condition is. So ASA 4 patients are not DA patients. So if you become a DA anesthetist in private, you're working alone, you shouldn't be doing patients who are coming in with heart failure, or patients with a ruptured aortic aneurysm, or patients with a bronchopleural fistula. That's not your patient, because those are very high-risk patients. Your patients mainly ASA 1 and 2. And then after you've done the risk stratification, you should have a plan. So your plan is to decide, am I going to do a GA? Am I going to do a regional procedure? What other things do I need in terms of monitoring? Do I need an A-line? Do I need a CVC? Do I need a urinary catheter with this patient? Do I need blood in theater? Do I need large bore lines? What other monitoring do I need? Do I need a 5-lead ECG? Do I need a cardiac output monitor? So all of those things are part of your plan, including with your analgesic plan and where you're going to send the patient post-op. Is it safe to send this patient to the ward, or should I be booking an ICU bed or a high care bed for post-op monitoring? So all of those things should come out in your plan. Then in terms of risk stratification, I added these slides just for you to have a look at that. I know most of you know about the ASA classification, but what I want to bring to your attention is that normal pregnancy, according to the new ASA classification, is actually ASA 2. So normal pregnancy is ASA 2. So if a patient is pregnant, she's got no hypertension, no heart disease, no diabetes, the new classification says they're ASA 2. And the reason why they say that is because of the tutorial that Dr. Mlitwa gave you last week, the changes that occur in pregnancy. The American Society of Anesthesiologists has reclassified these patients as being ASA 2. So ASA 1 is a normal, healthy patient who doesn't have any comorbidities. ASA2 is a patient with mild systemic disease. I also want to bring to your attention a patient who is a smoker is not an ASA1. A patient who is a social alcohol drinker is not ASA1. So if you've got one of your colleagues who drinks every weekend, that patient is not an ASA1. A patient who drinks alcohol minimally or occasionally is an ASA1. A patient who's obese is also not an ASA1, it's an ASA2. And you can look this up on the internet to find out what are the new classifications. Same thing again. I'm not going to waste any more of your time. ASA3 is severe systemic disease. ASA4 is a patient with severe systemic disease, which is a constant threat to life. So this is like a patient who's got has had a myocardial infarction, and they're at risk of having another one, or they've had a stroke and they're at risk of having another stroke, or a patient with a coagulopathy, or a patient with severe heart failure who can die at any time. That's an ASA4. Then ASA5, moribund patient, ruptured aortic aneurysm is the example they give, or uterine rupture is an ASA5 patient. So the obstetricians book a patient, uterine rupture, that's ASA5. So you must be very cautious with those patients. Then ASA6 is a brain dead patient for organ harvesting. As I said, your plan can be a GA, regional, whatever other thing, or sedation. So that should come out in your plan. Then once you've moved from seeing your patient, you now move to the operating room. So your operating room consists of your equipment that is there, your infusion pumps, your anesthetic machine, and other things that you might require. So it's very important before starting a case to check your anesthetic machine. So Dr. Folokwe covered this before, and he gave you some materials and YouTube links to checking the anesthetic machine. I will not go into depth with the anesthetic machine. However, I will say that you need to always make sure that you have backup oxygen in your hospital. So most anesthetic machines have a place where to put a backup cylinder. You need to make sure that your anesthetic machine has got a backup cylinder in case you have an oxygen failure. And your anesthetic machine must always be plugged into power. We've been having a lot of load shedding at the moment. If your anesthetic machine is not plugged in and fully charged, when there is a power outage, your anesthetic machine is going to immediately switch off. Most anesthetic machines are able to ventilate patients between 45 to 1 hour without a power supply, just battery powered. So that will give you enough time, if you've given a muscle relaxant, for the muscle relaxant to wear off and for you to think of another plan to ventilate that patient. So your machine must always be plugged. You must have a backup oxygen, and you must have an ambu bag, always, always. I've experienced it. If you've not experienced it, you will experience it one day. I've helped 2 juniors where the anesthetic machine failed, and we were saved by an ambu bag. I myself was saved by an ambu bag when the anesthetic machine failed, I think about 2 months ago. So always have your ambu bag, and it must be checked that it's working, and your oxygen cylinder must be there, and your anesthetic machine must be plugged, battery must be fully charged, and you must check your anesthetic machine on a daily basis. Otherwise, you will run into trouble and you are putting your patient at risk. Then other equipment that you need is your airway equipment. And in this diagram, what they did, they classify the airway equipment into plan A, plan B, and plan D. Plan C is the mask ventilation. So these plans are based on the Difficult Airway Society. So this picture is from the UK anesthesia group, which we kind of follow as well. So I'll just show you quickly the pictures of the Difficult Airway Society algorithm, which is due to be updated this year, 2022. So this is the 2015 guidelines, which were published 7 years ago. They still apply. So plan A is when you want to intubate the patient. What do you need? You need them to mask ventilate the patient, and then you intubate the patient. If you fail to do that, you're going to move to plan B, which involves using a a supraglottic airway device, that is a laryngeal mask airway. If that fails and you have got 3 attempts to do that, if that fails, you're going to move to plan C, which is mask ventilating the patient. If that fails, then you're going to go to front of neck access. So you can actually organize your trolley like this in your hospital to have a plan A, plan B, plan C, and a plan D. That will help you and guide you in the process of managing the patient's airway. So also another picture from the difficult airway group is they've got a difficult airway trolley, which they put into categories. Plan A is where you will find your ET tubes, your laryngoscope, and plan B is where you will find your supraglottic airway devices like LMAs. Plan C is where you will find your mask and your Giddels airway. Plan D is your cricothyroid, the equipment that you need to do front of neck access. So putting the trolley into this order as well will help your nursing staff to locate things. And I like this trolley because they even put a picture there. So if you're asking the nurse for an ET tube, she knows, she can see the picture, and the picture is always, they always say a picture is worth 1,000 words. So she'll be able to quickly open the first drawer and look for an ET tube. And in that drawer, you must put the ET tubes in the size of their orders, from the smallest to the biggest. Makes it easy. Same for plan B, you can put your LMAs in the order of smallest to biggest. Same with plan C, you can put your face masks and your Giddels airways in the order of size as well. So planning and having a certain level of order is very, very helpful when you are in an emergency, because you can't do many things at the same time in an emergency. You need extra hands. And it helps when things are organized like this, because people can get the stuff that you need very quickly. The other thing I didn't add on in this picture is suction. So suction is absolutely vital. And I don't start cases without suction. And I always drill in with the nurses, we need suction. We've had instances where in the middle of the op, the suction fails. So that's not a good situation, because it can happen that the patient self-extubates, or for some reason the tube comes out and there are secretions and you can't suction the patient. A word of caution, don't share the suction with the surgeons. I don't like sharing with them, because if you have an airway emergency and they are using the suction to suction blood and in a bleeding field, it will be difficult for you to switch or suctions and take their suction, because they're going to be very upset with you if you take their suction at that time, because they won't be able to see the surgical field. So it's always good to have your own dedicated suction and the surgeons to have their own suction. I know it's difficult in some hospitals, but you have to speak to the matrons to try and push for that, so that you have your own suction and you don't share with the surgeons and they have their own suction. Another thing also that Dr. Folokwe did outline is you must make sure that you have enough vacuum on that suction. Otherwise, it's not going to be effective. So that's a few words on suction. Defibrillator, extremely important. So some hospitals don't actually have the proper electrode gel. So the gel that you need for a defibrillator must be conductive gel, not ultrasound gel. Otherwise, you will burn the patient. So these are the types that are currently, I think they are on tender. They are in our hospitals. I have seen, we used to have gel aid in our institution. I am not seeing it anymore, but I've seen Signa gel, and I've also seen this one as well. So you just need to make sure that you have the right type of gel, because cardiac arrest doesn't happen all the time, especially in theater, it doesn't happen all the time. But I find there are more cardiac arrests happening in the wards, and nurses, when you ask for gel, they normally give you ultrasound gel. So that's not the appropriate gel. Always make sure you have the right type of gel. Then the defibrillators, according to the specifications, they need to be checked on a daily basis. And after you've checked your defibrillator, there is a printout that comes out. So most of the nurses have been trained to check the defibrillators. And once they get that printout, there is a book that they take this printout and they staple it into that book and they write the date to say that the defibrillator has been checked and it is functional. So most nurses have been trained to do this, but it is your duty as a doctor and an anesthetist in theater to make sure that your defibrillator is working. And it doesn't take even 1 minute. All you need to do with your defib is to check whether it can charge and discharge. That's the most important thing. If you need to use it. If it's got pacing function, you need to just make sure that you've got pacing pads and that function is working. So the most times we're going to use a defibrillator is either to shock a patient, to cardiovert a patient, or to pace a patient. And checking all those things will not even take you more than a minute. So it's unacceptable to not check the defibrillator. And if your theater does not have a defibrillator, you need to talk to your theater matron to make sure that you have a defibrillator, because according to the theater standards, your theater is lacking and it's not safe. So environment is also very important. I've seen some of the juniors, they anesthetize patients and they forget to put a BHAGA. So if the surgery is going to be more than 30 minutes, because after 30 minutes of being under anesthesia, especially when you're getting a GA, there are many physiological changes that occur that lead to loss of temperature in the patient. So the patient begins to lose heat. And after 30 minutes of an anesthetic, without any form of warming device attached to the patient, that patient is going to be hypothermic. If a procedure is quite short, that is under 30 minutes, you don't necessarily need to put a BHAGA on the patient. But if it's a long procedure, you need to prepare and you need to know which type of air warming blanket, because there are different types. Some cover the upper part of the body, some cover the lower part of the body. As you can see, this one covers the whole part of the body and leaves the surgical field clear so that the surgeon can be able to operate, and it's not going to interfere with the sterile field. So you need to just find out what type of BHAGAs you have and how you can conveniently apply them to the patient. And you need to think of these things way in advance, not when the patient is already cleaned and draped and you are struggling to get your BHAGA onto the patient. So patient positioning is also important. You have to plan for this. So it's part of theater preparation. You need to know for your surgery, what are they going to do? So if your patient, like we had about 2 weeks ago, patient was coming in for clavicle surgery, and the surgeon wanted the patient in a semi-sitting position. And as you know, that is a concern because when a patient is in the sitting position, blood supply to the brain can be hampered. And your blood pressures that you aim for should be on the higher side in order to perfuse the brain. So whenever the surgical field is above the level of the heart, there's a risk that the patient can have a stroke, and there's a risk of a venous air embolus, there's a risk of nerve injury, there's a risk of airway edema. So all of those things you need to think in advance. But most surgeries are performed in the supine position. Occasionally we do patients in the prone position. When you're doing laparoscopic surgery, the surgeons will ask you to put the patient in Trendelenburg position. So you need to be aware of that. Sometimes we put patients in the lateral position. You need to be aware of that. So the positioning is very important in that in these positions, patients can suffer nerve injuries, they can suffer soft tissue injuries, they can become blind, they can also be issues with the airway. So I always tell the guys, if a patient is going to be in the lateral position, normally put our patients in the lateral position when they're doing olecranon surgery. The surgeons like them in the lateral position. There's a risk that the tube if you put in an LMA, LMA will be dislodged. So I always tell the guys, please just intubate the patient. Don't even take any chances. You don't want that tube to go out. You don't want the patient to be extubated. So just intubate the patient, make sure you tie the tube very well. If a patient is prone, you don't want an LMA, it's gonna fall out. So you want to intubate the patient. in that case. If a patient is supine and they're not doing bowel surgery or anything of that nature where there's a risk of aspiration, you can put in, by all means, you can put in an LMA. So patient positioning is very important because it relates to the airway, it relates to hemodynamics, it relates to pressure points, it relates to nerve injuries, and also to do with how your lines are going to sit and how you're going to access the patient. So you need to prepare for this. The other thing I didn't mention is that in these special positions, there are also special beds. As you can see, this one, patient in a sitting position, the bed needs to be elevated in a certain way. If the patient is in the prone position, there are extra attachments that need to be attached. So you need to be involved as well in this positioning, and it's your duty as well to make sure that the patient is safe when the surgeons are positioning the patient. Another important aspect is theater ergonomics. So ergonomics has got to do with your positioning in terms of your work environment. So if you see the picture on the left, these are two surgeons that I think they're working in the ophthalmology theater. One of the surgeons you can see his spine is bent, and the other lady, her neck is bent. And if you look at the right picture on the right, the first surgeon is more comfortable. He's sitting in a more ergonomically friendly position. And she also is sitting in a more ergonomically friendly position. So ergonomics is important because you can actually end up having back injuries as a result of not being appropriately seated. So I always encourage the guys that when you're doing procedures like inserting lines, doing peripheral nerve blocks, ergonomics is extremely important because they affect your performance. And also if your ergonomics are not great, you're also going to cause injuries. So in terms of theater preparation, in terms of procedure preparation, always think also of ergonomics for yourself and also your team. So I also help the surgeons sometimes, even nurses. I always say to them, are you comfortable? And I tell the surgeon, I say, can I just lift the bed a little bit up for you? Can I lift your chair for you? And they're like, oh, thank you so much. Because they were actually struggling. And sometimes when the nurses are scrubbed, they may not be positioned properly, and they can't say that they are not, and they are afraid of being unsterile. So they just tolerate that wrong, that uncomfortable position. But it helps for us also to look out for our colleagues. So moving on to drugs. So we talked about the patient, we talked about the environment, the equipment. Now the last part of the triad is the drugs. So emergency drugs must always be drawn, regardless whether you're doing a spinal, whether you're doing a GA, whether you're doing a sedation. You must always have your emergency drugs because you never know. When you get too comfortable is when things go wrong. So you must always be prepared. So your adrenaline must be ready. So I, in my practice, do not draw adrenaline because I found that it's a waste. You normally end up just wasting it. If it's an adult in a cardiac arrest, I always keep my adrenaline vial with me. It's always there. In a cardiac arrest, I know it's not going to take me more than 10 seconds to draw. And in a cardiac arrest, in an adult, you're going to give 1 milligram. So it's just 1 ml that I'm going to draw. I've got my syringe, I've got my needle. So I don't draw adrenaline routinely for adults because most of the time when I give it, it's a cardiac arrest. But for the pediatric population, I always draw adrenaline because children have got a higher risk of becoming bradycardic. Why? Because their parasympathetic nervous system is more developed than the sympathetic nervous system. So adrenaline for children, the resuscitative dose is 10 mics per kg. So how do you do that? You take 1 amp of adrenaline, dilute it to 10 mils, then you're going to have 1 in 100, which is 100 mics per mil. You take 1 mil from that, you add it to a 10 mil syringe, and you add 9 mils of saline, then you're going to have 1:10, which is 10 mics per kg, which is what you want for a pediatric patient. So in case of a cardiac arrest, the dose is 10 mics per kg. Why is it important to draw your adrenaline for pediatric patients? It's because with children, it's complex. You need to calculate all your doses, and it takes a lot of time. In an emergency, you can get a brain freeze and you don't have time to calculate all these doses in emergency. So that's why your drugs must be readily available. So there's a term which says immediately available and readily available. So in a pediatric population, your adrenaline diluted must be immediately available. Then for other patients, like adult patients, ephedrine and phenylephrine must be immediately available because these are your go-to drugs in hypotension. And we know in anesthesia, our volatiles cause hypotension, it's guaranteed. So if you're not drawing your emergency drugs prior to giving you anesthetic, your practice is unsafe. For a spinal, the literature says 2/3 of all pregnant patients will develop hypotension as a result of a spinal. 2/3, which means if you have 10 patients in a day, 6 of those 10 patients will have hypotension. It's guaranteed. So for you not to have your emergency drugs ready, it means that you are being unsafe. So I have seen some of the medical officers, I've worked with them, because they have become so relaxed and used to anesthesia, they don't draw the ephedrine. And some of them call me to their theaters, "Doc, I'm having a problem." I'm like, "We need to give ephedrine," and the ephedrine is not drawn. Now we have to ask the sister to run and give and go and look for ephedrine. So your ephedrine must always be drawn. Phenyl must always be diluted. So the phenyl, we take 1 amp, we dilute it to 200 mils. That's how you do it. And you're going to have 50 mics per mil of phenyl. That's what you have in your bag. Ephedrine, 1 amp diluted to 10 mils. You have 5 milligrams per mil of ephedrine. That is what is internationally recognized. If you're doing it other way, that you are cutting shortcuts. So people sometimes draw ephedrine and put it in a 5 mil syringe. That is incorrect. It should be drawn in a 10 mil syringe in 5 milligrams per mil. Then atropine is not an absolute must. I don't really use atropine anymore because if a patient becomes bradycardic, it's better to give boluses of adrenaline. That's safer. And you need to really know why the patient is bradycardic. So if they are bradycardic because of hypoxia and you give atropine, you are worsening the patient's condition. If they are bradycardic because it's due to increased vagal tone, then there is a role for atropine. Otherwise, atropine also, it's quite a waste. I don't think I've used atropine in the last 6 months. I still have to be corrected. But adrenaline, I have used. Ephedrine and phenyl, I have used. So emergency drugs, absolutely important. They will ask you in the exams. Then anesthetic drugs, these need to be readily available. If you're going to do a spinal, you don't have to draw your propofol because it will be wastage most of the time. You just need to keep it close by you. Your scoline must be close by you in case you need it. And your opioids as well, they must be there. You don't have to draw them. Other drugs, antibiotics, antiemetics, those are other drugs that you will need, and reversal agents as well. They must also be there. So antibiotic, we always draw for our patients, unless it's an operation that doesn't need antibiotic cover, but most of them, they need antibiotic cover. So there are operations that don't need antibiotic cover. For example, eye surgery, you always need to just check with your surgeon. Sometimes you don't need antibiotic cover. Breast lumps don't need. Thyroid, you don't need. Parathyroid surgery, you don't need antibiotic cover. So, but most of the time, you need antibiotic cover. Then there's what we call the Swiss cheese model. So errors can occur and in terms of drug administration. But the Swiss cheese model says that if you can put certain safeguards, you prevent an adverse outcome from happening to a patient. So if you look at the picture on your left, they talk of a near miss, and then at the bottom of it, it talks of a medication incident. So all these pieces of cheese or slices of cheese are safeguards. They are things that can prevent mistakes from happening. And when I started anesthesia, I remember, I'll never forget, because Dr. Ninise is a consultant now. He was my senior at that time, and I was in theater, and he told me, he said, how do you put your drugs? Do you just clump them all together in front of you in an anesthetic machine, do you have a system? And in my junior years, I had absolutely no system. I'll just draw propofol, I'll draw fentanyl, I'll draw scoline, and I'll just put them on the anesthetic machine. But he said to me, that is not the proper way. You should have a system. Your induction drugs, you can put them on one side. The drugs you're going to give in the middle of the op, you can put them here. And then your emergency drugs, you put them somewhere else. So from the day that he told me that, I never changed my practice. I mean, I never went back, rather. I changed my practice. I never went back. So today, I still maintain that habit. Drugs that I'm going to use for induction, that's my propofol and my rocuronium or sux. I put them together on one side. They're always on my left. My opioids are in the middle. So like fentanyl, morphine are in the middle. Then on my right is my antibiotic, my reversal agent, my antiemetic is always on my right. I maintained that system. I've maintained that system for the last 5 years or so. And then my emergency drugs, I never put them close to my induction agents. They're always either on top of the machine or on the drug trolley. And I know exactly where they are if I need them. That method of assigning drugs to certain places is part of a safeguard. So it helps you prevent giving the patient a wrong drug. So I know when I'm reaching for my induction drugs, I go to the left. When I'm reaching for my emergency drugs, I go to where the emergency drugs are. So I'm never going to give adrenaline by mistake when I'm intending to give fentanyl. Because the drugs, if you remember, the vials look very similar. And if you give adrenaline as a bolus in a normal patient, you will have ventricular tachycardia and you will have a ventricular fibrillation. So you have to be careful because giving the wrong drug can lead to an adverse event. And sometimes some of the adverse events may be innocent, nothing might happen, like giving maybe fentanyl when you didn't intend on giving it, nothing will probably happen to the patient. But sometimes you may give a drug like rocuronium at the end by mistake, and then it prolongs the anesthetic, but nothing happens to the patient as well. You're just going to have a prolonged anesthetic. But sometimes if you give the wrong drug and it might be adverse, like for example, giving IV marking, that can be a disaster. So you need to have checks and balances to prevent this from happening. So having a system to say, I'm going to draw my emergency drugs. When I get into theater, I'm going to draw my emergency drugs first, and then you put them aside. Then the next thing, I'm going to draw my induction drugs. Then I'm going to draw my other drugs. And you keep to that system. It will save you a lot of heartache. Another system that has been put across to prevent drug errors is the labeling of syringes. So there are international codes that are used for different drugs. So red is for muscle relaxants, and that's an international code. Yellow is for induction agents. And I'm not good at colors. I don't know what colors this is, but I know this is the color for, this is the color, I think it's blue. Blue is for opioids. And I'm not sure if blue, yeah. And then there's phenylephrine. I'm not good at colors. I don't know whether it's turquoise or what color this is. But for vasopressors, ephedrine, phenylephrine, adrenaline, they all have this color. So color coding is extremely important. I had a talk with one of the ladies in Cape Town. Not all South African institutions have color coding and stickers in their institutions. I know with Cape Town, I think the Western Cape, almost all of them, they use stickers, they use color coding for drugs. It's standard in all their theaters, you know. Joburg, I think I saw the guys in Joburg, they don't. Here we're trying to move towards that. So it's very important to have color coding because that can also save you. It once happened to me. I was about to give a patient a drug and I think I lifted rock and I saw the color coding and I was like, no, this is the wrong drug, put it down. But if you don't have color coding, you can end up giving the patient the wrong drug. And the other thing, markers are not always good. Some of the syringes are not great. Your marker can even end up being rubbed out. So color coding will save you as well. Positioning, putting the drugs in certain places will also save you as well. Drawing the drugs in particular syringes. So some of you find propofol today, you're drawing it in 20 mils, tomorrow you're drawing it in 10, ephedrine, you're drawing it in 20, tomorrow you're drawing, so you're not consistent. But if you know, I always draw my fentanyl in 2 mils, or I always draw my propofol in this, I always draw my ketamine in this, that can save you from making mistakes as well. So if you're working with someone, they give you 10 mils and it's written morphine, you're like, no, I don't think so. That must be a mistake. I always draw my morphine in 20. So you need to know how you do it and you keep to that pattern. Another way as well for preventing errors on drawing drugs is a system called Tolman lettering. It's also internationally recognized. And if you look at the picture on the left, this is dobutamine and the other one is dopamine. It's easy to distinguish them because of the colors, and also the use of Tolman lettering helps you to distinguish them. I want to take you to the picture on the left, on the right corner, ephedrine and epinephrine. Okay, in South Africa, thank God we don't have epinephrine. We call it adrenaline. But if you were in America, they call it epinephrine. So ephedrine and epinephrine. You can see that the syringes, if these were stickers on the syringes and you are tired, you've been on call the whole night, there is a risk of making a mistake. So this is 10 milligrams, this is 10 micrograms per mil. But when you're tired, you might not see that properly. You can easily make a mistake. But if you go down, you'll see what they have done. They've adopted Tolman lettering. So here they put ephedrine. Here it's epinephrine. So they use Tolman lettering as a way to avoid having drug mistakes. Another measure that you can also put in to prevent drug mistakes is pre-drawn drugs. So these ones are already drawn from the manufacturer and they have these syringes. So they already come labeled and pre-drawn already. That can also save you from mistakes. So they could ask you in the DA, what measures can you put in to prevent drug errors? So I've basically just taken you through how to prevent drug errors in your institution and in your practice, and it will save you a lot, I promise you. So checklists are very important in anesthesia, just like with the aviation industry. So no pilot was going to fly a plane without going through a checklist, unless they are a negligent pilot. But they will always go through a checklist before they depart for any destination. And once they land as well, they will go through checklists. In anesthesia, it's similar. Though some people don't agree that anesthesia is like flying a plane, but there are a lot of similarities between the aviation industry and anesthesia. So checklists are absolutely important and they will save you from catastrophes. So one of the things that we've started to introduce in one of our hospitals is this checklist, because the nurses really asked for it to help them. So we compiled a checklist. If you want it, I can send it to you on a group. It's not copyrighted, but please just reference and say you got it from us. Because normally what happens once these checklists move from province to province, I mean, things that start here, I've found that some people just, what can I say, hijack our ideas. And because they can speak louder, they put their names on these things and then we are lost. And then we are kind of in the shadows. And then we say, hey, this came from us. And everybody says, nah, we don't think so. But this came from us. So we compiled this thing very easily for nurses, A, B, C, D. So A is the airway. So with your nurse, you can say, sister, here's A. What do we need for A? I males. We need an introducer, a bougie. M is our mask, McGill's, our airway, our ambubag, laryngoscope, LMA, ET tube, suction. That's all you need basically for the airway. And you can add the video laryngoscope if you have one, just to check that it's there. Then B is breathing. So you want to check your ventilator, and our nurses, some of them are skilled at checking for that, and they'll identify problems. So ventilator must be checked, the circuit must be replaced, filter for every patient, soda line, replace it, flow sensors are intact, your defend, which is what absorbs the water, it's called a water trap. Emergency oxygen cylinder must be present. And then C, circulation. So IV fluids must be warmed. Patient must have an IV line. There must be a giving set, a 3-way stopcock, pressure bag, blood warmer, drip stand, and your bay hugger, which is your forced air warming blanket. And then D, defibrillator must be checked. And D also is for your drugs, adrenaline, ephedrine, phenyl, and your reversal agents and other drugs as well that you might require. So when we came up with this checklist, we realized that it covers most things. So if there are some things that are missing here, I would really like your input so that we can be able to modify. But as far as I know, I have gone through this checklist with the nurses. I've looked at it. If you can get your nurse to adhere to this checklist, there will be nothing that's missing. You will have literally everything you need in your theater ready. So checklists are important. Then that's all I have for you guys. I don't know any additions, subtractions, anything you want to add. That's basically theater preparation. If I missed anything, please let me know. Does anyone have any questions? Any questions from anybody?
I was saying on the list that is ACCD, you can find a space for still warming devices for a machine.
Sorry, Doc, we can't hear you well.
Anaesthetic machine.
Yes, anesthetic machine, yes.
Yes. We can add on to that. Yes.
Oh, we put it under B, ventilator. We put it under B. That's the anesthetic machine.
Okay.
Yeah, we put it under B, ventilator. So you could change to anesthetic machine, but we opted to write ventilator. Any additions, anybody to this checklist? I will take a picture of it. I'll post it on the group. So I know some of you guys don't do anesthesia all the time. Maybe you get called now and again for a Caesar and you have to give the anesthetic and help. So having this checklist, you can even store it as a picture on your phone. And whenever you go in to give an anesthetic, you can just quickly look at this checklist and see. So there are other checklists that are circulated, ESMO checklists and all, but I found this checklist quite easy, A, B, C, D. It will just help you quickly with preparing your theater. Okay, we're just gonna go to the chat box, see, please find a place for machine on this list. Oh, okay. Warming devices. Oh, warming devices, we put it under Behaga. So you could even add an E to your own checklist and say environment. Yeah. I'm not sure if anybody has anything you want to add. Something that we missed in the preparation that you do in your institution. So I assume it's clear. So you're gonna be very well prepared for your theaters in your district hospitals. All right. Now, thank you, everybody. If there are no other questions, you can always post on the group if you've got other questions. We will answer. Thank you, everybody. Thank you for your time, and we'll see you.
Thank you, Doc. Thank you.
Yeah.
Thank you very much, Doc.
All right, guys. All the best.